Okay, so good evening, everyone. Sharif Awad, consultant bariatric surgeon from EMBMI in Royal Derby Hospital and educational lead for BOMSS. Lovely to see you all again. It's the 24th of August, 22, and we're running the educational webinar tonight, the fourth Wednesday of the month, as we've been doing for the last 2 years. So thank you to Medtronic for sponsoring the educational webinar tonight. Gives me great pleasure to see Professor Iskandar Idris from the University of Nottingham. So he's Professor of Metabolic Medicine, and he is based at the University Hospitals of Derby, my unit at the EMBMI. And he's going to be talking to us about mechanisms of diabetes remission, really important topic actually, following weight loss surgery. But just before I hand over to Professor Idris, just an advert for our next two sessions. So the next journal club will be the 14th of September, run by the Coventry MDT, the bariatric MDT, and then the following 2 Wednesdays on, so the 28th of September will be Denise Ratcliffe, who many of us know, a fantastic consultant psychologist. She'll be delivering a webinar on that evening. So without further ado, I'll hand over and thank Professor Idris very much for speaking to us this evening. Please post your questions via the Q&A button, and I will chair the Q&A at the end of the talk. So it's a 30-minute session. And as always, we record these sessions, and hopefully early next week, we're going to be sending our quarterly roundup, sending out emails to the links of all the recordings. Okay, so thank you very, very much, Iskandar.
Thank you very much, Sharif. You want me to wait for a bit longer? Yes, you suggested earlier that we might.
You can start. You can start.
Okay. Can you see my cursor here?
Yeah, looks perfect. Thank you.
Excellent. All right. Thank you very much, Sharif, and the organizing committee for BOMSS for asking me to speak at this e-seminar educational event. So as mentioned, my name is Iskandar Idris. I'm based at the University of Nottingham, and I work closely with Sharif at the East Midlands Bariatric Metabolic Institute. My remit in the next half an hour or so is to provide a brief overview on our current understanding on the mechanisms of diabetes remission following bariatric surgery. So this audience will know that obesity is a complex and multifactorial disease. And we know that the reason where people develop obesity is not just due to a gross imbalance between excess energy intake and reduced energy expenditure, driven by lifestyle circumstances, but also regulated by a variety of neurohumoral factors, by adipose tissue, pancreas, and gut, which secretes a variety of hormones and cytokines, as well as genetic factors and medications which patients may take and may perpetuate weight gain. And these drives the experience of palatability and pleasure, which causes further increase in energy intake and reduced energy expenditure. And as such, obesity is associated with multiple chronic comorbid conditions. So we're all familiar with these variety of conditions such as sleep diseases, lung disease, non-alcoholic liver disease, cardiovascular disease. There is a very close link between excess obesity and the pathogenesis of type 2 diabetes. So not surprisingly, obesity contributes to about 44% of the diabetes burden. And certainly within our unit, the comorbidities at presentation at our tier 3 and subsequent tier 4 service, about 1/3 of our patients have type 2 diabetes. Now, the achievement of tight glucose control is crucial for the management of patients with type 2 diabetes. And this is really to reduce the risks of long-term complications causing blindness, kidney failure, cardiovascular disease, and neuropathy. We know, for example, obese patients with type 2 diabetes have a significantly higher risks of developing renal failure, not just because of the risk of hypoglycemia, but we know that obesity itself can cause increased protein leak in the urine, which drives diabetic nephropathy. And therefore, the major components for the treatment of type 2 diabetes are simplified by means of diet and exercise to induce weight loss and to maintain lifestyle factors. For many patients, they require oral hypoglycemic therapy. And if their glucose control remains elevated, they will need to be commenced on injectable therapy such as insulin or GLP-1 injections. Now, in patients with obesity and type 2 diabetes, it's crucial that we maintain their weight because of the pathogenic link between obesity and the progression of type 2 diabetes. Achievement of weight loss, but also maintenance of weight loss is important in order to prevent the progression of type 2 diabetes. We know from a variety of clinical trials that maintenance of weight loss is very challenging. So these are some studies which have randomized patients to receive lifestyle intervention versus normal measures. And as you can see, all these studies induce significant weight loss at time of early intervention. During follow-up, many patients regain their weight, and in fact, some patients, they have their weight increase compared with baseline. And this is because of the well-recognized physiological responses to weight loss, which favor weight regain. So for example, once we induce weight loss, a variety of physiological factors conspire to push our hunger and desire to eat in order to increase weight as well. And this results in resting energy expenditure, and also it adversely affects metabolic adaptation. So different strategies are important whenever we are looking at strategies to achieve tight glucose control in our obese patients with type 2 diabetes. This is also important because the variety of treatment for type 2 diabetes, namely insulin and sulfonylurea, as well as pioglitazone, confers additional weight gain. So this slide shows data published in New England Journal of Medicine, where patients are randomized to receive intensive medical therapy versus Roux-en-Y gastric bypass and sleeve gastrectomy. And as you can see, there is significant reduction in HbA1c with gastric bypass and sleeve gastrectomy, which is maintained over the duration of the study, whereas there is an initial dip in HbA1c with medical therapy, but there is seemed to be a relapse. What's also important is, if you can see in this picture here, the number of diabetes medication to achieve these HbA1c remains high. So at least a minimum of a median of 3 glucose lowering therapy, whereas bariatric surgery induces a reduction in number of diabetes medication, such that at 12 months, the mean number of diabetes medication is just under 0.5. And this is associated with significant reduction and maintenance of BMI and reduction in fasting plasma glucose. So bariatric surgery have become a very important tool when managing obese patients with type 2 diabetes. This is data for diabetes remission, because not just the fact that bariatric surgery confers a significant reduction in HbA1c, there is significant interest in the role of bariatric surgery in diabetes remission. This was really observed in the 60s and 70s, but the evidence for diabetes remission has accrued quite significantly in the last decade or so. So this data published in Diabetologia suggests that the remission rate at the moment for bariatric surgery ranges between 60 to 75%, depending on the types of procedure. You can also see that during follow-up of patients, the remission process is a dynamic process because, apologies for that. So the remission process is a dynamic process simply because at different times of follow-up, patients remit and relapse and remit and relapse. So at about 60 months, there is still a persistent high number of patients who remain in diabetes remission. In the same paper, they undertook a regression analysis to predict the groups of individual where non-remission is highly likely. So what they've shown is that individual above the age of 50 and certainly above the age of 60 years old are independently predictors of non-remission, as well as those with diabetes duration of more than 8 years, those with high HbA1c at baseline, and patients who are on insulin therapy. So it doesn't mean that these individuals are not going to remit, but the chances and the probability of remission, if you are above the age of 50 with prolonged diabetes duration and on insulin therapy, be much lower. And indeed, this is all data from Derby, but just reflects the remission rate that we see in our hands, which is comparable to national and international data, where at 12 months post-op, we are looking at about 78% of remission rate, and the remission rate remains elevated further at 48 months of post-operation. So it's important to just look at diabetes remission as a whole, because one of the problems we've had in the last few years, and certainly in the last 10 years, when you're looking at studies to predict or to calculate diabetes remission, is that different studies utilize different definition for diabetes remission. So the most common definition that was quoted before was HbA1c of less than 6.5% for 1 year, for example. And some, certainly in America, they use a lower HbA1c cutoff for remission rate. More recently, there is a global definition based on consensus statement, which suggests that diabetes remission is defined as individual with a HbA1c of less than 48 millimoles per mole for at least 3 months, and not taking any medications to manage their blood glucose level at that time. Apologies for this.
What's happening? Is that a problem with the PowerPoint?
Sorry, yeah, sorry, just hold on for a minute. There's a problem with PowerPoint. Can I just unshare for a minute?
Okay.
Can you hear me?
Yeah.
You can't hear the talk behind it.
I can just hear you. I can't hear anything.
Okay, that's fine. So I'll go back to my slides earlier.
Thank you.
So yeah, so this slide, look, so it's in order to understand diabetes remission, it's really important to understand the pathology in terms of progression of type 2 diabetes. So for example, this slide shows a relationship between insulin sensitivity and beta cell function. The brown line refers to normal glucose tolerance level. So basically, in patients who remain on this line and they don't develop diabetes. So as insulin sensitivity goes down, there is increase in insulin production to compensate for the reduced insulin sensitivity. And provided this adequate amount of beta cell function compensate for reduced insulin sensitivity, patient will remain in normal glucose tolerance. However, when there is a defect in beta cell function, where beta cell fails to compensate for the reduction in insulin sensitivity, that's when diabetes occurs. Now, the reason why I mention this is very important because it tells us that in order for diabetes to remit, we need to make sure that the beta cell works again. So even though insulin resistance is important, beta cell function is the crucial pathological player that drives diabetes, but also remission. So this is the first phase insulin response in diabetes, where when insulin is produced, there is increase in amount of insulin produced from the beta cell. And as you can see, the first phase insulin response in people with diabetes is significantly impaired. So our understanding on the mechanism of reversal of type 2 diabetes have become revolutionized with this very important study published in Newcastle back in 2011. And in this study, patients were exposed to very low calorie diet, about 600 calories per day. And this was exposed for about 6 weeks. And what this study showed was that there is significant increase in insulin response with very little change in peripheral insulin resistance. Now, the improvement in insulin response results in resolution or remission of type 2 diabetes without any changes in peripheral insulin resistance. And this study provided this twin cycle hypothesis, which explains the pathogenesis of type 2 diabetes. Essentially, what the twin cycle hypothesis suggests is that when there is excess energy intake, this results in increased fat production in the liver, and this drives hepatic insulin resistance, which causes a spill out of lipids and VLDL into subcutaneous fat tissues, and therefore you get increased islet cell triacylglycerol. And when you've got this increased fat in the islet beta cell, it causes dedifferentiation of the cell, causing diabetes. And therefore, in order to induce remission of type 2 diabetes, it's important to remove the islet triacylglycerol from the beta cell so that the pancreas and the beta cell starts to produce insulin and restore the first phase insulin secretion again. And in fact, a very low calorie diet was studied in the DIRECT study, where individual exposed to 3 months of very low calorie diet was associated with significant remission of type 2 diabetes. For example, in the DIRECT study at 1 year, there is 45.6% remission rate of type 2 diabetes. But in fact, the remission rate reduced slightly at 35.6 after 2 years. So essentially, calorie restriction by means of very low calorie diet can induce diabetes remission, as would be the case for bariatric surgery. But in fact, data here suggests that the remission rate is quite low, i.e. 45% compared to the 75% that we're quoting from data that we've seen in clinical trial. But also there's a relapse rate such that remission rate is lower after 2 years of very low calorie diet. So this data suggests that there are additional mechanisms that drives diabetes remission from bariatric surgery. And one of the thought was the mechanism of diabetes remission is the secretion of GLP-1. So this is data from Annals of Surgery, in which patients were underwent bariatric surgery, and GLP-1 level was measured, and they looked at the independent predictor of diabetes remission. And what this showed was that those with high GLP-1 level seems to have a higher risks of diabetes remission compared with those whose GLP-1 level is quite low. So what is the GLP-1? So in order to understand GLP-1, it's important to understand the incretin effect. So the incretin effect relates to the fact that when glucose is given orally in green, compared with a comparable glucose challenge given intravenously, there is increase in insulin production with oral glucose compared to intravenous glucose. And the difference between the amount of insulin produced as a result of oral versus IV glucose is known as the incretin effect. And the incretin effect really suggests that there is a hormone that sits within the GI tract that is responsible for the incretin effect. And we know that these hormones are the GIP and the GLP-1 hormones. So GLP-1 has a variety of favorable effects in humans. The important aspects of GLP-1 is that it crosses the blood-brain barrier to promote satiety and reduces appetite. And in fact, this was seen where GLP-1 activates areas of brain which is involved in appetite regulation in dynamic MRI studies. With regards to diabetes, GLP-1 has an important role in inducing insulin secretion from the beta cell, reduces glucagon secretion from the alpha cells and slows gastric emptying. So all these metabolic effects favors reduction in glucose and diabetes remission by increasing beta cell response and reducing beta workload. And we know that GLP-1 analog, when given patients with type 2 diabetes, will cause an increase in insulin secretion and restore first phase insulin response in people with type 2 diabetes. So the enteral effect of GLP-1 is the fact that feeding by means of nutrients such as proteins, carbohydrates, and fats activates gut peptides, neurotransmitters, and therefore increase beta cell function. So this study shows the effect of gastric bypass on GLP-1 level. So you can see that gastric bypass in patients who's had previous gastric bypass was asymptomatic hypoglycemia, or patients who has had gastric bypass who suffers from hypoglycemia as a result of dumping syndrome, both of whom have significantly increased GLP-1 level compared with control. And also, patients who have gastric bypass also have increased GIP hormones, and both GLP-1 and GIP-1 level is increased significantly following gastric bypass and is responsible for the incretin effect and the restoration of insulin secretion. So a lot of the effects of GLP-1 is really explained by the hindgut hypothesis, where early transit of nutrient into the terminal ileum within 5 minutes of nutrient ingestion causes a rapid rise in GLP-1 level, which is thought to improve the first phase insulin secretion and restore beta cell function. However, there's also another mechanism which relates to GLP-1, and this relates to the foregut hypothesis. And this foregut hypothesis, as shown here, was first introduced by work by Professor Rubino, where he undertook studies in rat, where bypassing the duodenum, so bypassing causes a significant increase in glucose metabolism and glucose insulin resistance, and suggesting that there are unknown factors or anti-incretin effect which is responsible for the favorable effect on glucose metabolism. So this was supported. This is a study that I was involved a few years ago, where we undertook duodenal mucosal resurfacing by endoscopic procedures. This is in collaboration with the Nottingham Digestive Centre, where patients were randomized to receive duodenal mucosal resurfacing to sham. And what we did was we introduce an endoscope within the duodenum and destroy temporarily the lining of the duodenum. And independent of weight loss, the resurfacing of the duodenal mucosa conferred a significant reduction in HbA1c level without weight loss. So this suggests that the foregut hypothesis, which relates to bypass, may itself induce favorable metabolic effects, which also has a beneficial effect to induce diabetes remission. Another important mechanism is the role of gut microbiota and bile acid. So we know, for example, that gastric bypass surgery as well as sleeve gastrectomy results in increase in bile acid secretion into the duodenum. And once the duodenum and the ileum is exposed to high level of bile acid, crucial aspects here is that bile acid in the terminal ileum reacts with the FXR receptors, which stimulates FGF19, and it also interacts with this G protein receptor, which causes increase in GLP-1 and PYY secretion. Now, FGF19 is a very interesting molecule that is being currently studied in metabolic physiology, because FGF19 has favorable effects not only in glucose metabolism, improvement in beta cell function, but also may confer benefits in people with non-alcoholic fatty liver disease. So we know, for example, that patients who have had bariatric surgery, where there is a deletion of the FGF19, there is impairment of their beneficial metabolic effects, whereas patients who has no deletion of FGF19, you get preservation of their benefits in metabolic effects. Similarly, patients with high FGF19 level post-bariatric surgery are more likely to induce diabetes remission compared with people who has lower level of FGF19. So high amount of bile acid, which spills into the duodenum, will stimulate these receptors, which again confers favorable effects in glucose metabolism. In addition to that, gastric bypass mainly, also sleeve gastrectomy to some extent, also significant alterations in gut microbiota flora, and which includes increased diversity of the gut flora and altered composition, as well as beneficial effects in certain types of bacterial species, all of which is favorable for glucose metabolism, increased insulin sensitivity, and therefore preservation of beta cell function. So I've talked mainly about GLP-1, insulin, restoration of the first phase insulin secretion, as well as the role of bile acid and gut microbiota. What about the insulin resistance and insulin sensitivity? So for many years as students, we've always assumed that what drives diabetes and obesity is insulin resistance. But in fact, I've mentioned earlier that remission of type 2 diabetes is driven primarily by restoration of beta cell function rather than improvement in insulin sensitivity. But insulin resistance and insulin sensitivity also plays an important role following gastric bypass and sleeve gastrectomy surgery. So in simple terms, normal insulin sensitivity person, adipose tissue and triglycerides either oxidize by non-acerate fatty acids or glucose in the muscle, and this relates to normal insulin sensitivity. However, in obese and insulin-resistant individual, there is excess adipose tissue which drives lipolysis at the expense of glucose oxidation, and as a result, you get hypoglycemia and obesity-induced insulin resistance. Now, the amount of fat that is removed and the type of fat is also important. So, for example, this is a study looking at the effect of liposuction on metabolic outcomes. And as you can see, despite significant reduction in waist circumference following liposuction, the amount of glucose, the amount of insulin, and the cardiovascular risk factors remains the same. So it's not just the fat that's important to be removed, but also the type of fat that needs to be removed, such that the small fats within the viscera, or what we call ectopic fat, which lines the liver, spleen, omentum, are metabolically active, and therefore removal of these fats via calorie restrictions is crucial to improve insulin resistance and insulin sensitivity. And this is shown, for example, when visceral fat is removed, a significant reduction in cardiovascular risk profile, as well as reduction in HbA1c level. So this is a very nice study published in Diabetologia by researchers from Italy, University of Pisa. What they did was they looked at the effect of gastric bypass surgery on tissue-specific insulin sensitivity among patients with type 2 diabetes. What they did was they looked at the early and long-term effects of gastric bypass surgery. So the rhomboid arc circle here refers to healthy volunteer with normal BMI, so BMI of about 23. And as you can see, lean individual has a significant reduction in hepatic glucose production compared to obese individual, have increase in insulin sensitivity compared to obese individuals, and they have a reduction in fasting glycerol, which is a measure of lipolysis. So when there is increased lipolysis, as I mentioned before, there is a significant impairment of glucose oxidation and therefore insulin resistant. Now, the red circle represents individual who had bariatric surgery with type 2 diabetes. So as you can see, the first arrow reflects the impact of hepatic glucose production at 2 weeks following bariatric surgery in patients with type 2 diabetes. The data suggests that early weight loss at 2 weeks post-bariatric surgery is really driven by loss of water, which is related to post-surgery dehydration and water loss. And as you can see that there is a significant further reduction in hepatic glucose production at 1 year. Similarly, insulin sensitivity increased in 2 weeks of bariatric surgery, and this is really driven by calorie restriction. Whereas at 1 year, the regression data suggests that this is driven by weight loss. And similarly, reduction in lipolysis was seen at 2 weeks, which continues at 1 year. So what this data suggests that the insulin sensitivity, the improvement in insulin sensitivity in the liver, as well as lipolysis, relates to the amount of weight that patients have lost. So there is clear, significant relationship between weight loss with improvement in insulin sensitivity. The improvement in insulin sensitivity at 2 weeks post-surgery was driven by calorie restriction, and the improvement in insulin sensitivity at 1 year is driven by weight loss. Now, this is another study which again looked at the effect of gastric bypass surgery on insulin sensitivity, and you can see there's a clear correlation between insulin sensitivity and BMI, suggesting that there's no other factors other than weight loss which drives improvement in insulin sensitivity. However, there's an exception to that, and this is an individual who received biliary pancreatic diversion. Now, the main difference with BPD compared to gastric bypass is that BPD induces significant lipid malabsorption. And when there is significant lipid malabsorption, there's significant reduction in intramuscular lipids, and therefore reduction in lipotoxicity at the beta cell, and hence the insulin sensitivity improvement following biliary pancreatic diversions seem to occur above and beyond weight loss, i.e. independent of weight loss. But of course, BPD is not a widely used bariatric surgical procedure due to the severe complications that patients experience. Suffice to recognize that the improvement in lipid metabolism is also very important in order to achieve supraphysiological level of insulin sensitivity. So just to summarize, I'm coming to the end of my talk now, of the potential mechanism contributing to the remission of diabetes following gastric bypass surgery. So we've talked about calorie restriction causing a restoration of first phase insulin secretion, as well as the rapid emptying of nutrients into the small intestines and stimulating GLP-1 secretion, which in itself also causes improvement in and restoration of first phase insulin secretion. Removal of the stomach fundus causes a reduction in ghrelin hormone, particularly in the sleeve gastrectomy, which improves insulin sensitivity. And also we've talked about the foregut hypothesis, where exclusion of the duodenum and proximal jejunum from nutrients confers benefits, although we're not clear of what hormones is responsible for this. The evidence for this was supported by our study using the duodenal mucosal resurfacing strategy, where exclusion of the duodenum by means of destruction of the duodenal mucosa causes benefits in glucose levels independent of weight loss. And I've also mentioned about the enhanced nutrient and bile acid delivery to the distal duodenum, which stimulates the receptors responsible for increased production of GLP-1 as well as FGF19 within the terminal ileum. And these are the potential mechanisms which mediates this immediate impact of surgery. And this includes changes in gut microbiota, changes in intestinal adaptation. So we know, for example, gastric bypass surgery causes increase in villus hypertrophy and increase in villus height in the roux limb. And this causes increase in intestinal glucose absorption and therefore reprogramming of intestinal glucose to confer benefits in glucose homeostasis. And all these changes results in improved beta cell function, improved insulin sensitivity, and reduced hepatic glucose production, resulting in HbA1c reduction and therefore remission of type 2 diabetes. And I'm just going to finish off with the fact that we are currently investigating by means of dynamic MRI imaging, mapping, and spectroscopy to track the effect of very low calorie diet, this is sleeve gastrectomy, this is gastric bypass surgery, to further understand the mechanism of diabetes remission in the variety of insulin sensitive organs such as the liver, pancreas, and the muscle. So thank you very much for your time, and I'm happy to answer any questions, and I'm sorry about the problem in the midway of my talk. Thank you.
Thanks so much, Iz. Really complex, comprehensive topic, very nicely summarized. So there's been quite a few questions from the audience, so I'm quite keen to crack onto those. If you just unshare your screen.
There you go.
That's lovely, thank you. Okay, so first question here, would you recommend the use of GLP-1s earlier in the treatment of type 2 diabetes in patients with BMI over 35 rather than waiting to try the oral agents?
Yeah, definitely. So the current guidelines suggest that when individuals have a BMI of 35, we should use glucose lowering therapy, which induces weight loss, and the best of these agents are GLP-1. The problem is access to these therapies, such as semaglutide, because some GP practices are not set up to start injectables, and they have to refer. And so we've had a lot of problems with this, but I agree that's the most effective therapy in individuals above BMI 35.
And similar GLP-1 question, why do some patients appear not to tolerate GLP-1?
So the main side effect is nausea, vomiting, feeling of fullness. There's different sensitivity to GLP-1. So some people are super sensitive to GLP-1 and therefore they're not suitable for it. But we often start patients at low dose and move the patients up slowly. And sometimes if they can't tolerate higher doses, then we just push them back down to the dose that they can tolerate. The side effect profile of GLP-1 relates to the circulating level of GLP-1 in the blood. Okay,
all right. And a couple of questions on a similar theme in terms of offering patients bariatric surgery within a stretched, within NHS stretched resources. So should we be offering bariatric surgery to patients with diabetes who've had it over 10 years, given that we know they're less likely to go into remission? Is there still any benefit for those patients?
Well, I think obviously there is benefits in obese patients with type 2 diabetes, because diabetes is a progressive disease and weight loss maintenance is difficult. It is likely that diabetes will progress and patients will be introduced to newer therapies, so on and so forth. So, I think it's not just about diabetes remission. Diabetes remission is obviously the holy grail. A significant improvement in glucose control, restricting patients to just one therapy rather than 3 or 4 therapies, these are important goals of treatment. And I think based on that, it's important that patients do have access to bariatric surgery if suitable. Obviously, the problem again is access to bariatric surgery, well-known problems with waiting lists and everything else. But I would suggest that there is significant benefits in bariatric surgery in suitable patients who are significantly overweight.
Okay, question here about sleeve versus bypass in patients with diabetes.
Yeah.
What's your view on that?
Well, I think current evidence suggests a slight favor of gastric bypass in terms of glucose metabolism, mainly because there are other non-weight loss dependent effects that, as I've explained before. So, for example, the issue of gut microbiota, even though it's seen in sleeve gastrectomy, changes in gut microbiota is more significant with gastric bypass. And similarly, the effects of GLP-1, the early introduction of nutrients to terminal ileum, it favors gastric bypass. As I've mentioned before also, changes in insulin sensitivity correlate strongly with weight loss. There are no other mechanisms, at least from the data we know, of improvement in insulin sensitivity above and beyond weight loss, apart from in patients who have bad biliary pancreatic diversion. So I think current evidence slightly favor Roux-en-Y gastric bypass in patients with type 2 diabetes, but sleeve gastrectomy is very effective in people with type 2 diabetes as well.
And just of note, the sleeve pass randomized control trial, which was published in JAMA this year, no statistically significant difference in diabetes remission at 10 years between sleeve and gastric bypass. So lots of other factors to take into account, reoperations, the safety of the profile, the patient preference, etc. Dealing with that question. Is there a way of anticipating the response of diabetes improvement or remission, especially in patients on injectables? For example, urinary C-peptide, is that of any value in anticipating the response of diabetes improvement or remission?
In predicting, you mean?
Say again, sorry?
Is it in predicting diabetes remission?
Yeah. Is there a way we can predict better which patients will have improvement or remission of diabetes apart from the factors you identified?
Probably not. I think it's based on well-recognized factors such as patients who are not on insulin, patients with low HbA1c level, younger patients, they tend to do better, and whether they induce diabetes remission will depend on the follow-up of the patient.
Okay. Question here about how long a patient can remain on Saxenda or Ozempic.
So this is a hotly debated area in among the metabolic physicians. The reason why it's hotly debated is all the data suggests that when you stop this therapy, you get weight regain. The problem is in the UK, at least, the current NICE guidelines limits it for 2 years. So when you look at studies and follow-up studies, you ideally, if patients are doing well, and they're maintaining their weight loss, and you should just continue because of risk of weight regain. But unfortunately, current guideline limits us to 2 years. Okay,
that's UK guidance. Is there any international guidance?
There's no international guidance, but randomized control trials and follow-up observational studies suggest ideally to continue these therapies due to risks of weight regain.
Okay, I've got a couple of quick ones just from me. So we often, when we counsel patients, we talk about diabetes remission. Some advise patients to come off diabetes medications completely. Is that right? Is that still the appropriate advice, that patients should come off their metformin completely after surgery? Or what would you advise a post-op weight loss surgery patient regarding medications, and when do you recheck the HbA1c post-op, etc.?
I'd probably recheck HbA1c post-op at 8 to 10 weeks.
Okay.
In terms of glucose lowering therapy, it depends on the HbA1c level, obviously. So
if it drops into the normal range, would you stop metformin? Or
no, I'd probably stop everything else except metformin.
So you carry on.
I would my preference is that we should stop metformin once the HbA1c is below 42. Because obviously at 42 to 48, you're in the pre-diabetes range, and there is, benefits of continuing metformin, at least in those patients within that range. But once HbA1c is less than 42, then there's no indication for metformin therapy.
Okay.
Obviously, some people stop metformin earlier.
Yeah, they do. Yeah, they do. But in terms of the cardioprotective effects of metformin,
I think
with a normal HbA1c level,
probably very minimal, I would have thought. Yeah, the cardioprotective effects of metformin, data for that is very, very scarce. That it's based on small number of patients, so I don't think it's strong enough for us to use that as a rationale to continue metformin beyond lower HbA1c levels.
Very quick advice from you to the audience about eye screening. So patients who have rapid control and improvement in their blood glucose, what's your advice about eye screening?
Yeah, so I mean, we've shown this and we've published this data as well. There is significant increased risks of progression of diabetic retinopathy following rapid normalization of HbA1c level. However, these patients who are affected tends to be those who has diabetic retinopathy at baseline, or at least what we call sort of more progressive diabetic retinopathy. So in patients with no diabetic retinopathy or just background diabetic retinopathy, the risks of rapid progression to sight-threatening retinopathy is very, very, very low. So in patients who have what we call R2, that means these are pre-proliferative changes, or maculopathy, then they should have earlier eye screening following bariatric surgery.
What time frame?
So normally patients have yearly assessment. So I'd probably say within 4 to 5 months.
4 to 5.
Just in terms of how we do it in pregnancy, because in pregnancy there's a rapid, in pregnant diabetics there's a rapid reduction in HbA1c for physiological reasons. So these people with background diabetic retinopathy or pre-proliferative retinopathy, they have the eye screening much earlier on during their pregnancy rather than waiting for another year.
Okay, no, good advice. A question has just come in. Thoughts on the safe cutoff for HbA1c pre-op? And we've discussed this plenty in our MDT.
Yeah.
The cutoff that we agreed is 100 for HbA1c. So any more to add?
That's just an arbitrary cutoff, because really when you look at the evidence, there's no clear evidence above which HbA1c cutoff is associated with very adverse outcomes. There are theoretical reasons why it might be bad. I think it depends on patients. I mean, my sort of reading of this is when HbA1c is a chronic measure of glucose control. So when HbA1c is checked, it might reflect the HbA1c level prior to their liver shrinkage diet, or as we've seen in the data that I've presented earlier, within 2 weeks of bariatric surgery, there is significant reduction in insulin sensitivity and everything else, and that's on bariatric surgery. And many of our patients will have 2 weeks, 3 weeks, or even 4 weeks of liver shrinkage diet prior to bariatric surgery. So by the time they come in for their surgery, there's a 2 to 4 weeks period where their glucose control has improved dramatically by means of calorie restriction. So their HbA1c may not necessarily reflect what the HbA1c or their glucose level is at the time of surgery. So, I mean, we can select an arbitrary cutoff of 86 or 100, which is what our guideline is. I think it should be individualized to patients. So if we think that our patients are not complying with the liver shrinkage diet, they're not complying leading to surgery, and their glucose level at the time of surgery is very high, and irrespective of the HbA1c level, then these patients will run into trouble in terms of perioperatively, post-operative healing, and various other things. So I think it should be individualized to patients is my way of looking at it.
Okay, good advice. Let me give you a scenario. So say 40-year-old female, BMI 50, been through her hospital pre-op, not known to have diabetes, been through the hospital pre-op process, HbA1c comes back as 60. So it's a new diagnosis of diabetes immediately pre-op, going to do a 3-week liver-reducing diet. Should the operation be put on hold for the GP to start the oral diabetes medication or carry on with bariatric surgery?
I'd probably say no. I don't think it merits a delay if the patient is all set up and the HbA1c is 60, is newly diagnosed. The liver shrinkage diet will provide further reduction in glucose control by the time of surgery. So I don't think there is a rationale to delay this particular patient surgery.
Okay. Final question from me, then I promise I will let you go. Operation fatigue and weight regain in the future. If diabetes was to recur again in the future after weight loss surgery, is that mainly as a result of weight regain, or are there other metabolic factors that take effect? Do we know?
Well, as I've mentioned, remission and relapse occurs. It's driven by beta cell function. So when patients induce a remission of diabetes, it means that beta cell is working again. So when they relapse, it means that their beta cell is not working again, and it's usually because of accumulation of triglycerol or fat deposits in the beta cell. So a lot of the work from Newcastle, where they investigate the mechanisms of diabetes remission, talk about what they call personal adipose threshold. And by that they mean different people have different adipose threshold that they need to remove in order for their beta cell to work again. So in some people, they need to remove a lot of fats from the beta cell for their beta cell to function again. And in some people, they just need to remove a bit of beta cell, and then the beta cell works again. And to some extent, it depends on how differentiated their beta cells are following glucose toxicity and lipotoxicity they've been exposed to many years. So in patients who's had bariatric surgery, they induce weight loss, they remove their fat from the beta cell, and their beta cells working again with first phase insulin secretion, very healthy. They have this period of diabetes remission. But as they accumulate food intake, maybe there is an increase in triglycerol being laid down in the beta cell, a slight increase in insulin sensitivity, and sometimes those are enough to tip them back into the diabetes state. So it's a combination of weight regain as well as metabolic factors that causes a relapse of diabetes.
And post-op, should we be doing an annual HbA1c?
Sorry?
Post-operatively?
Yes, of course, yeah.
Should we be doing an annual HbA1c on all patients who've gone into remission?
Definitely, yeah. So
because I don't think we do that in our clinical practice once we patients.
The GP should be doing that. And even if they've had diabetes remission, they still have to have retinopathy screening. They still have to have their nephropathy screening and their neuropathy checked. Because these complications, particularly if it's present, won't go away despite diabetes remission. So, the remission means that the HbA1c is well in normal range, but they have the propensity to relapse at any time. So that's why it's important to monitor the HbA1c lifelong. So
do the GPs know this, and do they do this?
Yeah, generally in patients who have diabetes remission, GPs will continue their screening for complications and HbA1c level. Yeah.
Okay. Okay, that's it. Okay, fantastic. Iskandar, thank you ever so much for your time tonight. Really good talk, presentation and discussions. We'll email the link to the video recording of tonight so you can forward to colleagues. Next session, Journal Club run by the Coventry MDT. That's on the 14th of September, Wednesday. And then following that, 28th of September, Denise Ratcliffe for the next educational webinar. So thank you ever so much for joining tonight. And again, thank you very much, Iskandar. Good night all.
Thank you very much.